Hello dear colleagues, I'm Gerd Otto from the University Medical Center of Mainz, Germany. I'm glad to have the opportunity to report on our recent work, how to decide about liver transplantation in patients with hepatocellular carcinoma, size and number of lesions or response to TACE. For more than a decade, we have performed liver transplantation in HCC patients meeting and exceeding the Milan criteria after repeated TACE. The reason to adopt this form of pretreatment was not only to bridge the waiting time, but, and importantly, patients whose tumor did not progress during TACE had a very low rate of tumor recurrence. This was our experience and the experience of others, first of all Henri Bismuth's group in Paris. Another issue was that the assessment of Milan criteria in pre-transplant imaging is hampered by a high rate of incorrect classifications. Therefore, one may question, what is preferable in selecting patients, the static assessment of the Milan criteria or the assessment of a dynamic process, namely the response to TACE? According to the study protocol, patients clearly exceeding the Milan criteria were included. Notably, the maximum diameter of a single tumor or of the sum of all nodules was 10 cm, irrespective of the number of nodules. Patients with microvascular infiltration and extrahepatic disease were excluded. All TACE procedures were performed using lipiodol and mitomycin. Every patient had at least 2 cycles of TACE. Patients meeting the Milan criteria were immediately listed, but patients exceeding Milan were listed after 3 cycles of TACE if there was a partial response or stable disease, whereas patients with progressive disease were not transplanted. After listing, all patients underwent transplantation in order to scrutinize the influence of further tumor response to pretreatment. At 2 points in time, the imaging, usually CT scans, were evaluated before initiation of pretreatment and before transplantation. Thereby, 3 forms of classifications were used. First, the assessment of the Milan criteria. Second, conventional RECIST classification. And third, assessment of so-called any progression, considering any form of progression even if less than 20%. Notably, in the statistical evaluation we focused on the main oncological criterion, namely tumor recurrence, whereas death from other reasons was censored. Now the principal results in some aspects which may be discussed. Without going into detail, I would like to stress that the evaluation of Milan criteria in imaging compared to the specimen was incorrect in 32% in the initial CT scan and 26% in the imaging after TACE, that is before transplantation. The point is that patients assumed to meet and to exceed the Milan criteria in the initial imaging had identical recurrence rates following transplantation. When the 3 dynamic classifications, changes in Milan criteria, response according to conventional RECIST, and evaluation of any progression were included in the receiver operating characteristic to assess their predictive capacity for tumor recurrence, we attained a surprising picture. The 4 possible changes occurring in the Milan criteria, Milan out-in, in-in, out-out, in-out, resulted in the blue line, delineating an area under the curve of 0.764. The 4 categories of the RECIST classification accounted for 0.794, the yellow line. But the best prediction was achieved when the criterion any progression was used, 0.855. Once again, the predictive value of the initial Milan criteria was like tossing a coin. What is the profit resulting from this study? It appears to be difficult to correctly assess size and even more number of tumor nodules in imaging available before transplantation. The visibility of changes in imaging occurring during pretreatment is much higher. The question arises if these changes reflect a selection process or if tumor stability over a longer period means no more than just proof of time. Anyhow, we strongly advocate a large multi-center study in order to test these results. In view of organ scarcity, particularly in Germany, a modification of the allocation criteria in HCC patients amenable to liver transplantation appears to be desirable. I thank you for your attention.